The broadcast is now starting. All attendees are in listen-only mode.
Welcome to the Aquatic Therapy University's Definitive Aquatic Precautions and Contraindications List webinar. My name is Andrea Salzman. I'm a physical therapist. I'm the Director of Programming for Aquatic Therapy University. And I'm here today to talk to you for about an hour about the precautions and contraindications that a lot of people tend to think about when they think about putting someone into the water. There's a lot of lists floating around. Every facility truly has their own list. What is an aquatic precaution? What is a contraindication? I'm going to try and hash that all out for you today. So as I said, my name is Andrea Salzman, and if you want to contact me at any time after the webinar, you can reach me at asalzman@aquaticnet.com, and that email address is down at the bottom of your screen and should be on your handouts as well. So I'm the Director of Programming for Aquatic Therapy University, and just briefly, we offer aquatic therapy trainings to therapists across the globe. We do 2-week intensives, oftentimes for foreign students, although we do have American students that come for 2 weeks at a time to do our 84-hour credentialing tracks. So these are just some pictures of our live instructionals. And starting 2 years ago, we started doing webinars just as a nod towards the fact that a lot of facilities, especially hospitals, are getting hit hard in these times and need to train their staff at home. Okay, so what are we going to talk about today? We have 4 objectives. Number 1, we're going to talk about the importance of maintaining a very short contraindications list and a very long precautions list. Next, we're going to hit the fact that sometimes it's important to seek additional orders or additional authorization from the referring provider, and what are the situations that make that come to pass. Number 3, we're going to actually discuss what are the precautions and contraindications that a lot of facilities tend to think of as definitive, and what number 4 is basically what research expert opinion backs up those premises. Because there's certainly a lot of phone calls that I get personally from facilities and from patients who are saying things like, you know, the therapy pool in our town says if my husband is urine incontinent, he can't get into the pool, which is certainly you know, not a frank contraindication and barely a precaution. And we'll talk about that as we move on. Okay, first, why should you maintain a very short contraindications list and a very long precautions list, especially in the aquatic therapy setting? Well, if you think about it, there's as many lists of precautions and contraindications as there are therapy pools. And the problem is, if you label a condition a contraindication versus a precaution, it really removes your capacity to have any leeway. If you label a condition, let's say open trach, or a stoma site, if you label that as a precaution, it allows you, the therapist, the ability to have some discretion and to weigh the cost versus the benefits of taking a patient, putting them in the pool. So if you had, let's say, a child who had an open stoma, and you could speak to the parents, to the physician, you can talk to your colleagues, you can make arrangements so that there's more than one therapist perhaps present to control them. The patient has good cognitive skills and you feel comfortable about putting them in the water. It's not someone who's going to spontaneously dunk themselves underneath the surface of the pool. You might choose to put that patient into the water. But if you label it as a contraindication, especially if you put it in your policy and procedure manual, and I'm here to tell you that medical malpractice attorneys adore policy and procedure manuals. They can't wait to get their hands on your policy and procedure manual and look at your list and see what you yourself said is a contraindication. So if you put something down as a contraindication, you better never, ever place that in the pool. If something is a contraindication, it really takes the discretion out of your hands. You can't then go back and say, well, yes, it's a contraindication, but in this situation, I'm going to allow it because it's such a high potential for you know, benefit. So let's say that you had someone that was like a Rancho stage 3 or 4 you know, coma patient, and their mother said, oh my gosh, if we could just get this child into the pool, I know that he would wake up. He's, he loves the water. He was a fish before he had his accident. And, please, 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 can we just put him in the pool? And the speech therapist is telling you that they're on thickened liquids and they have all these aspiration precautions and they don't have a functional cough and they certainly don't have the cognition to know, how to keep their mouths closed. And you choose to put them in the pool because you think, oh, the benefits, the mom is just so sure that this is going to be something that's going to make them alert and arouse them. And then they aspirate. If you had placed in a condition such as on thickened liquids on your list of precautions, then you maybe have, a row to hoe. You can say, well, I talked to the physician, I talked to the family, we documented what was going on, and we didn't think that there would be a high aspiration precaution. But if you've placed it on your contraindications list, you're sunk, okay? So I would strongly recommend that you have a list of contraindications because each facility does have its own list of things that they never, ever want to put in the pool, but that list be relatively short and your precautions list be much longer. Okay, so how do you decide what is what? Which is a precaution and which is a contraindication? I am not going to be able to tell you what your facility should put in which list, but I can tell you that there are several conditions that have kind of a spectrum. So for example, on your precautions list might be fecal incontinence. So let's say that you put all fecal incontinence on your contraindications list. Well, that means that you can never place anyone who is incontinent in the water, fecally incontinent. So think about your spinal cord injury patients who is incontinent, yes, but they're on a digital stimulation program every morning or every other morning where they are digitally stimulated and their fecal matter is removed, or you take someone who has very firm stools and is constipated and they're very aware of when they have to have a bowel movement, and they can, even though they can't control it, they can tell you when that's going to happen. If you put that on fecal incontinence on the contraindications list, then that removes the capacity. If instead you put diarrhea on the contraindications list and you put fecal incontinence on your precautions list, then that leaves you a little bit more leeway. The CDC says that diarrhea is a frank contraindication to immersion in a public pool. So when you look at the end of this webinar and you look at our additional resources page, I'm going to give you the link to the actual information from the CDC that says that if someone has diarrhea, that they are not supposed to be in that public pool for 2 weeks after the last bout of diarrhea. Now, I know that this is really hard to police, and especially when you've got adults who are incontinent, they will often not tell you that they're incontinent, and they certainly won't tell you that they have diarrhea. So a lot of times what we'll do at the beginning of a session before we ever run into the situation is give them a list of things that are conditions that you need to be made aware of as they come up, and that they sign this form that says they understand that if they have diarrhea, they're still going to get therapy. They can still come to their therapy session. It's just that they can't get into the water, and it's for their own health and the health of other people. And so sometimes if you can broach it before the situation comes up, it becomes less of an issue. Okay, so another example of kind of a spectrum of what might be a precaution and a contraindication is something like congestive heart failure. So stage 1, stage 2 congestive heart failure patients often do phenomenally well in the water. And in America, we tend to be a little bit on the take higher precautions with our cardiac patients than some other countries. When I look at the Japanese literature, they've taken stage 3 congestive heart failure patients and put them in hot tubs for 15 minutes and assess how they how their left ventricle handles the load and the heat. And when you look at some of the Finnish research, some of the things the Finns have done, they'll take a brand new baby and put them in a hot tub and then roll them in the snow and see how they handle the thermal variations. So, I don't think it's a bridge too far to say that when you have someone that's in congestive heart failure, there's ends of the spectrum on it. And certainly anyone who's in congestive heart failure, stable congestive heart failure, should have, that should be on the precautions list. But when someone's in decompensated congestive heart failure, or the final stages of congestive heart failure, that is probably something that needs to be on your contraindications list. And again, at the end, we'll give you the references that back this up. And then just lastly, as another example, is if you've got someone who's on aspiration precautions, but they're very cognitively intact and they're aware of their situation, they're able to keep their mouth closed, they don't have so much tone or spasticity that you're not able to control them in the water, you might choose to put them in the water, in which case just being on aspiration precautions is not something that you would put on the contraindications list. But if someone has a poor cough reflex and they're on thickened liquids and they're on nothing by mouth orders, that might be something that you choose to say, that is not a patient that I would put in the water. I personally would still not put that on the contraindications list because it's not cut and dry. I would put it on the precautions list and then always have an eye towards it as I put that patient into the water. Okay, so objective number 2. Let's look at what the conditions are that should make you think, just because the doctor referred this patient to therapy, especially if your clinic is the type of clinic that doesn't have a special check-off box for aquatic therapy. And that's a whole nother discussion, whether you should have that or not. I think there's pros and cons. There's pros because it makes your physicians aware that you have aquatic therapy and that you offer this specialized service. There's a con because it makes it seem like aquatic therapy is this different monster, this different breed of therapy, and that it's not just occupational therapy in the water or physical therapy in the water or athletic training in the water or whatever it is. And so then it makes it seem like you need this special permission for it. And then that also brings to mind the fact that sometimes you do need special permission for it from the payer, because there are some payers that will authorize aquatic or will authorize physical therapy, for example, but will not authorize physical therapy in the water. Or, for instance, in Minnesota, where I worked for many, many years as the manager of a therapy pool, we had a payer who would pay for 20 visits of 20 visits of physical therapy per year, and an additional 5 visits of aquatic therapy, which just blew my mind. And I can remember going to my manager and saying, let me talk to them and explain to them that aquatic therapy is a procedure. It's not a profession. It's not a discipline, and that they should roll those visits, into physical therapy and just give us 25. And I remember she told me, don't you dare talk to them, because what they'll do is they'll say, great, okay, aquatic therapy is part and parcel of physical therapy, so now you have 20 visits of physical therapy, and you can choose to have those be aquatic or not. She said it will actually take away 5 of your visits. So I never said anything, but when you put aquatic therapy on your order, essentially what you're saying is, there's something different about this. And as I said, there's a pro to that. The con to that is that it does make it seem like you need special permission, whereas truly evaluation and treatment should leave the discretion up to the therapist. Now, that said, take a second and start thinking about what are your top 5 reasons that you stop, pause, and you take a moment and you go, yes, they wrote evaluate and treat. No, we don't have a special box that you check off aquatic therapy, but boy, I'm going to call up the referring physician or the referring provider, and I'm just going to make sure that they know that I'm going to put them in the water, and I'm going to do that before I ever put them in the water. And, people will say, oh, well, if let's say it's a Medicare patient, you're going to send your forms back to the doctor and they have to sign them anyway. Well, you and I both know that that happens oftentimes quite after the fact, and that there are very few referring providers who sit down and read your plan of care. If that's news to you, I'm sorry, it's true. They might scan what you're doing and sign it, but they're just as overworked as you are. So if you have anything that makes you think, not sure, I would just strongly recommend that you pick up the phone and that you obtain additional authorization. So these are some of the things that come to my mind. Okay, so if you've got, let's say, a little child, a baby with osteogenesis imperfecta, brittle bone syndrome, and that child is not allowed to be moved passively, and so you think the pool is this perfect place because they're not going to have the effects of gravity bearing them down. The freedom of moving in the water, the buoyancy of the water is going to make it possible for them to move actively, so I don't have to try and passively move their limbs. Yet, this child has brittle bone syndrome, and so that's something that I might think, before I put them in this environment that is potentially turbulent and, potentially offers lots of freedom of motion, I might run that by the doctor the first time. Secondly, if they have an open trach site, if you have open trachs listed on your contraindications list, then you shouldn't be putting them in the pool at all. But if you have it on their precautions list and you're thinking, I can make a case for putting this patient in the pool, and I'm here to tell you that pediatric clinics across the country put patients with trach sites. They put a barrier on it and put them in the water, and it never comes up that it's an issue. But for most adult therapists, it's a little bit more of a thought process because this is not something that they typically treat on an ongoing basis. And so if you have any concerns, then you should pick up the phone and say, listen, this is my plan. What do you think? Okay, if they have a low T-cell count or some sort of immunocompromise, certainly if they're already on any sort of isolation precautions, they should not be in your pool, period. But if they're hovering low near kind of the cutoff point and you're thinking, even though our pool chemicals are great and we take care of our environment, it is a public pool. You are recirculating water that is the same water, and just because it's been disinfected does not mean that every particle, every molecule of water is disinfected, because every molecule of water does not go through the system every time it circulates. And so if you've got a system that circulates 4 to 6 times an hour, that doesn't mean that every molecule of water goes through the system 4 to 6 times an hour. It just means on average over the course of the day, all of that water is going to be disinfected. Plus, if you have someone with an immunocompromised status and they're standing next to somebody who has a fecal accident, or who has an open area that they didn't cover, or who, heaven forbid, spits up in the water, or whatever, it may take 10 minutes or 15 minutes for E. coli to be destroyed by chlorine. So just something to think about. If you have any questions about whether they should be in this public bath, a disinfected bath, but a public bath, then you should contact the referring provider and just make sure that you're both on the same page. Okay, post-operative period. I would say this is probably the one that I think of the most often. And usually you get a kind of a consensus with the physicians, the operative physicians. This is usually the orthopedic surgeon, but it can certainly be a neurosurgeon as well. So you go to the physician, you say, listen, we want to kind of establish our post-total knee replacement or post-total hip replacement, posterior approach, anterior approach, whatever, protocol with you. And look, here's some of the literature that suggests that, let's just take the total knee, that early aquatic therapy is very beneficial for that total knee replacement patient. And by early, I'm talking 5 to 7 days post-op. And that is a discussion you really need to have with a surgeon, because there are many surgeons out there who would hit the roof if you put their patient in 5 to 7 days post-op, even though there's been a systematic review and a meta-analysis that both back that up. So you'll have many surgeons who say, nope, not until their stair strips are off, not until they come back for that follow-up visit at 2 weeks post-op, and there's even some physicians that say not for 30 days. And so certainly it's your job to try and promote the cause, especially since there's all this evidence, which again you'll be able to download at the end of the webinar. But if your surgeon says do not put them in until 18 weeks after their surgery, then A, do not put them in until 18 weeks after the surgery, and B, probably don't send your mother to that surgeon for a total knee. So I would say the post-op issue is the #1 reason that I call and follow up with the referring provider, especially if I don't have some sort of protocol on hand. Okay, suprapubic catheters. When patients have just regular condom catheters or indwelling catheters for the most part. We'll talk about this a little bit more later, but for the most part, the condom catheter you just remove, the indwelling catheter you just have them put on a leg bag, and you drain the leg bag, and you have them pull on a pair of biker shorts over top so that their tubing doesn't wiggle too much. But a suprapubic catheter is just kind of a horse of a different color. So some surgeons, or some not surgeons, but some physicians are vehement. They're like, I don't want my patient with a suprapubic catheter in the pool. It's too high a risk for infection. It's too big a deal to replace and put it back where it's supposed to be. And so no. So that is something that you need to know the physician's preference, or you need to follow up and make sure that you're both on the same page. Okay, what if the patient just had a heart attack and they were a great big swimmer before the heart attack? Well, anything about 6 to 8 weeks after a new cardiac event like that, they really shouldn't be in the pool. And we'll talk about the specifics, but if you have any question, if you're close enough, if you're not sure, gosh, I don't know if that's just going to be too soon, just follow up with a referring provider, because you don't want to be the reason that their newly damaged heart now has too high a load on it because of all the hydrostatic pressure that's pushed this fluid back up into the ventricles. You really don't want to be the reason they have another heart attack. And then what about weight-bearing status? Obviously, the pool is the perfect place to work on weight-bearing in a modified capacity, because the more immersed they are, the more the weight is removed from compression. The issue is to be completely non-weight bearing in any setting, even the pool, is very difficult to achieve. I can remember when I worked in a nursing home, I was the manager of, 3 nursing homes that I would go around to, and I can remember sometimes a woman would fall and she would get a pelvic ring fracture, and I'd think, oh my gosh, no, and they would do it. They would put her on non-weight bearing status for 8 weeks, and I'd just think, oh my gosh, just take her out back and shoot her, because 8 weeks of non-weight bearing status in this 92-year-old woman who's got mild dementia, and it's just, she's going to get respiratory complications. She's her bones are going to get thinner, and she's going to fall, and it was almost like a death warrant to say non-weight bearing. And in those kinds of situations, how ideal would it have been to allow someone some limited time in a therapy pool? But non-weight bearing means non-weight bearing, and if you've got someone in the water, it doesn't matter how deep you immerse them. If you allow them to do a compressive force, let's say by pushing off on the bottom of the pool if they're standing up, or by pushing off on the side of the pool if they're lying supine, or even by pushing off against you, then that's a compressive force. So again, if someone is truly a non-weight bearing status, which is not that common anymore, most people are touch down or toe touch weight bearing, but if they are true non-weight bearing, then you probably need to have a discussion before you put them in the water. So those are my kind of things that come to mind. If you have other questions about what are the diagnoses that make you pick up the phone and make that extra call, then you can email me after the webinar. Okay, so let's actually talk about what our definitive list is. What are the precautions and contraindications which you should consider before you put anybody in the water? And again, I'm going to list these, but almost exclusively I'm going to say these are either a precaution or a contraindication. And I'm not going to make that decision for you, because that's going to be completely up to you, your infection control department, your referring physicians, and your conscience. So I'm going to list them all in kind of a hodgepodge. They're really in no order, but it's going to be up to you to what you put on that contraindications list, with the caveat that you never, ever put somebody with that condition in the pool if you do put it on the contraindications list. Okay? All right, so what are they? Well, first of all, anyone who is at risk for aspiration. So anyone who's aspirated before, who's had aspiration pneumonia for sure, anyone who's on thickened liquids, anyone who has an absent or poor cough reflex, anyone who's got an order for nothing by mouth, anyone who the speech therapist says, don't, give them a glass of water down in therapy. You're basically putting them in a huge body of thin liquid. water. And a huge body of thin liquid that moves, and a huge body of thin liquid that moves without warning. And the more people that are in the pool, the more possible it is to get splashing, and the less cognitively aware the patient is, the more possible it is for them to do something completely unpredictable and spontaneous, like decide to do a nasty plunge back into the water. So anyone on aspiration risks is, you put a little asterisk by there and you say, okay, what's the worst that can happen if they do aspirate? And why would I want to put them in the pool? What's the great big hurrah that I get at the end of this process that makes me think, absolutely, I want them in the water. It's worth it. Okay, even more of an issue is if they have an open port to the lungs. They have a trach site, a stoma, and of course you can cover this. There are even trach snorkels. There are adults who swim laps with something called a trach snorkel. There are even people who put on a cover on the trach site and surf in the ocean, which just boggles my mind, absolutely. But those are adults. And they're cognitively intact, and they know their own body. If you're dealing with a patient who is a child, you have another layer of complication, which is the fact that they're not making a choice by themselves and that their cognition is not as developed as it could be. So you have to make that decision. And again, I will tell you that for the most part of the pediatric clinics that I've worked with and have instructors for Aquatic Therapy University, those instructors from pediatric clinics oftentimes see people with open ports to their lungs that they just cap and cover, and sometimes have a second hand or an aide or somebody helping with them, but put in the pool. But again, a higher level of precaution certainly than just an aspiration risk. Okay, G-tubes or NG tubes or any sort of tube. An NG tube, you just cap, and you can tape it out of the way so that it doesn't get caught as the person's moving through the water. There's very little about an NG tube that requires any additional thought. You just obviously want the end of it to be capped. The G-tube, most physicians allow their G-button babies or their people with G-tubes to get in a pool. They don't want them to get into the lake or a pond or a hot tub. And I'm here to tell you that a hot tub is a very, very small pool with a very, very high temperature. So and a very, very large bather load. And those three things tend to make it a little bit of a petri dish, especially in hotels and facilities that don't take care of their hot tubs. And I'll just give you an example. I once attended a class or a conference that was full of water microbiologists and public health officials, and the entire conference was on water quality. And the hotel that we were at had these gorgeous hot tubs, like three variable size hot tubs that had these cascading waterfalls and all. And the entire time that I was at the conference, I never saw one person using any of those hot tubs. And it was kind of a point of discussion because these were the people that know best what the water quality in hot tubs is like, especially in a public setting like that. But back to G-tubes, if it's a therapy pool or a swimming pool with this large volume of water and a relatively low temperature and a very small bather load, the risk goes down dramatically. And so a lot of physicians don't even have their G-tubes covered before they get in the water. Some want you to put on a piece of gauze and then a piece of Tegaderm over top of it. But especially in the pediatric setting, a well-established G-tube is a precaution and not often a contraindication. Okay, what about an ostomy, like an ileostomy or a colonoscopy or colonoscopy? Ostomy. Well, it depends. Is it well managed? Certainly if this is someone who has a brand new ostomy bag and they have no idea how to get a good seal on it, the skin is freshly cut and macerated, that's not someone that you would want to have in your pool. But if someone has a well-managed ostomy and they always have a good seal on it, and they know how to control the situation that they have, then you can make that cognitive choice. So certainly someone who knows how to empty their bag and get a good seal should do so obviously before they get in the pool. They should empty out their bag and make sure the seal is good. And then a lot of times if you just wrap an ACE wrap around and pull on a pair of biker shorts. And for those of you that are interested, there is an in-depth article that ATRI, which is the Aquatic Therapy and Rehab Institute, had in a journal. It's now defunct, but back when it was being published, they had a very nice article on applications, ostomies, and so on. And I will make the link available to that at the end of this webinar as well. So it went into much more detail about how to prep the skin and how to make sure there's a good seal and what to wear on the outside. But ostomies, for the most part, are precautions and not necessarily contraindications unless your facility chooses to make it so. Okay, open wound or maceration. Well, it depends. Is the open wound a surgical wound, a clean surgical wound that has surgical approximation and, you're 5, 6, 7, 8 days post-op, then you might choose to put a piece of Tegaderm on top of it and get into water. If the open wound is on a diabetic, if it's on a diabetic foot especially, which is farther away from the circulatory main frame, then you better have a pretty compelling reason for putting that patient in the pool, because you don't want the skin to get macerated around it, and you don't want the chlorine or bromine or whatever it is that you have in your pool to irritate that wound. I guess the least of the concerns is the fact that if that wound is infected, that you don't want that infection to go into the water. But mostly what you're thinking about with an open wound is, what is it going to do to this patient? If it's a clean open wound, it still doesn't mean, yes, you can just get them into the water, because, again, especially if they're diabetic, kind of the primo importance of treatment is for that wound to heal. And so you need to have a really high benefit to risk ratio for putting them in the pool. Okay, take a picture, or take a look at this picture and see if you know what part of the body this is. This is actually the waist, and you can see the band, which is where the waistband had some elasticity that went around it, and this is where the bathing suit was the snuggest. And this is what a chlorine rash or contact dermatitis because of a halogen like chlorine looks like. It looks an awful lot like a sunburn. It's kind of diffuse, it's red, it's not a spot, it's all over the place. And if you're trying to decide if a rash that you got after, or your patient got after being in the pool, if you're trying to decide what brought on that rash, really the easiest way to make that decision is how quickly that rash came on. If the rash came on, almost immediately, 10 minutes after you got in the water, all the way up to almost 24 hours after the fact, then it's probably a contact dermatitis. The earlier it comes on, the more likely it is a contact dermatitis. If you get some sort of rash or breakout, a day, 2 days afterwards, it's probably not a contact dermatitis or a sensitivity to that halogen. It's probably some form of bacterial infection that you got from the pool not being taken care of. So again, it's a time consideration when you're trying to make that diagnosis. The other thing that I'll say about chlorine sensitivities are they don't resolve. So unless you've got some special circumstance like pregnancy, or you're on a certain kind of medication, or you have that special sensitive skin that happens right after radiation for cancer, if you're getting into a pool, or your patient is, and the chlorine level at that pool is at 3 parts per million, and you're getting a contact dermatitis rash, sensitivity to that, you are probably always going to get that rash at that level of halogen. It's not something that comes and goes. In fact, it's something that can become more severe as time goes on. And so I have sadly seen a lot of my colleagues over the years, who have been in the water for, 10, 12, 15, 20 years, get to the point where they can no longer get into a pool that has higher levels of halogens, like a 5 parts per million chlorine level. And then I've even seen some people who had to quit the profession altogether because even a level of maybe 1 part per million was too much for them. And that kind of leads us to a clarion call for supplemental systems for disinfection, like ozonators and ultraviolet light, because those systems allow you to manage your halogen levels a little bit better and not perhaps be at the higher end of whatever your state regs require you to be at. Okay, how about environmental infections? And by environmental infections, I mean things like, athlete's foot, and maybe lice, and things that you're going to get in the peri-pool area and not even necessarily in the pool. So let's talk about athlete's foot. You're not going to get athlete's foot in the water. You're going to get it on the way in, on the deck. You're going to get it in the bathroom. The more stuff there is in the bathroom and on your deck, the less your bathroom and deck are getting cleaned. So whenever I help people design their therapy pools and they show me all this stuff that they're going to put on their deck, these tables and these chairs and this place to do documentation and this cart that doesn't roll and and all these things, this water fountain that goes almost all the way down to the bottom to the floor, but not all the way to the floor, doesn't have a pedestal. Every time I see this 6-inch clearance underneath something or a 1-foot clearance underneath something, it just or clutter, like lots and lots of chairs. It just means that whoever's cleaning your deck is not going to do a very good job because it's a pain in the rump to have to move all of that stuff, and so you end up mopping or steaming around those things. And environmental infections like athlete's foot happen in poorly cleaned areas like your bathroom. And there's just a lot of people that are in there with a lot of bare feet, and it's not going to happen in the pool, but it is going to happen. So, some places will say, I'd like you to wear flip-flops coming in, and some people will say, that's a risk for tripping and falling, and so we're just going to keep our decks, pristine. Lice, the CDC, pretty interesting. The CDC actually has something to say about lice, but has said that lice do not abandon ship when you get into the pool. So even if you have someone that has lice in their hair and they immerse in the water, they cling to the hair follicles and they stay put. Where you have to worry about it is in the locker room. I still, to this day, go into some locker rooms at some pools and we'll see kind of the communal property. It'll have the lotion and the hairspray, and I'm not kidding you, a brush that is left out there, and some towels and such. And so anytime that you have people sharing accoutrements like that, you're going to run into a possibility of transmission. Okay, diarrhea, we already talked about a little bit before, and again, this is probably one that I would put firmly in your contraindications list. Diarrhea is way worse than a firm fecal stool. I mean, perhaps the sight of the baby Ruth floating by you in the pool is more alarming than somebody having a little squirt of diarrhea in the water. But I'm here to tell you that the diarrhea is far more transmissible because every little piece of poop has 3-dimensional access to the water, and so you're transmitting whatever ish is in that at a far higher rate than you are if it's a contained fecal matter. Plus, you can always scoop the baby Ruth out, chlorinate, and you know that you didn't get this wide dissemination before you did so. Okay, how about infectious diseases? So for example, MRSA or crypto or TB. It is, as we're doing this webinar, it's the tail end of 2013, and the NFL is kind of getting plagued right now by this widespread transmission of MRSA in their locker rooms. And the CDC has actually said that there has been quite a lot of MRSA swapping, which is just Staph aureus that doesn't respond well to the most popular medication that normally kills Staph aureus. It's been known to transmit in whirlpools in high school athletics, college athletics, but we've never seen it as we've seen it recently at the professional level. And it's because you've got these athletes, and they've got all these cuts and scrapes and wounds, and they happen to be infected with MRSA, and they're sharing whirlpool facilities. Now, there is an article that talks about chlorine killing MRSA within a couple minutes of immersion, and at the normal levels that you would see in a therapy pool, MRSA should not transmit. That said, the CDC says if you have a open site that is cultivated with MRSA, so I'm not talking about, in your body you have MRSA, because about a third of the population now has MRSA because of all these nosocomial infections in the hospital. But if you have, port that has been cultured with MRSA, that you should just not get in the pool. So don't bother covering it with Tegaderm and getting them in the water. Just tell them until that closes, they should not get in the water. Okay, if someone has an infectious respiratory disease like a cold or the flu or TB, certainly TB, the pool is this warm, viscous, humid environment that all these nasty airborne infections and droplet-borne infections thrive in. And so they really should not be in the pool setting because of how transmittable that is. All right, lastly, this little round ball that you see that says Cryptosporidium oocyte, I always think about crypto as being like, the candy that has a little hard candy shell on it. Crypto is the bane of pools everywhere, and if you get a crypto infection in your pool, then you're probably not going to get back into your pool for a month, and you may never open the pool again. It's such a hard infection to get rid of because crypto does not respond to chlorine. So if you have this little oocyte and you drop it in Clorox bleach and you let it sit there, it's going to take about 2 weeks for it to eat through that hard candy coating on the outside and kill what's on the inside. And that's why fecal-borne contaminants like crypto are so much worse than blood-borne contaminants. Everybody worries about things like HIV and hepatitis and these blood-borne pathogens, but the truth is the CDC says that you could cut your arm off and bleed out into the water and not have to shut your pool. Now, they said, it's kind of funny because you don't think about the CDC as having a sense of humor, but at the bottom, it has this little caveat which says you may choose to shut your pool down for public perception's sake, that person's bleeding out into the water, but that any blood-borne pathogen is instantly killed by, being in this properly chlorinated pool. And viruses like HIV don't live outside the body anyway, even if it wasn't a properly chlorinated pool. So blood-borne pathogens are essentially a very low risk of transmission versus something like a fecal-borne contaminant, which oftentimes has a protective mechanism. Okay, cardiac diseases. We're going to try and fly through this, but there's a paper that you can download at the end that I go into the 5 top myths that there are about cardiac disease and pulmonary disease and putting them in the water. So I'm going to hit these pretty fast, but you can read a much more detailed paper at the end. Okay, so there's been a myth in place that aquatic exercise has been shown to produce these dangerous stressors on the cardiac system, and so that no cardiac patient should be in the pool. And when you look back to see where this came from, it came in the 1970s when all this literature came out about the effects of swimming. And swimming and aquatic exercise or therapy are two very different things. So we're going to talk about why they're different and what distinction that should make. Okay, so swimming and vertical exercise, which is what most of your cardiac patients are going to be doing, they produce completely different hemodynamic effects on the body. And that's because when you're immersed vertically, you get the effect of hydrostatic pressure. So the hydrostatic pressure, and again, I'm not going to go into this in kind of the depth that I would in a 16-hour class, but you can download the paper at the end. But hydrostatic pressure is the greatest at your foot and less so at your abdomen or your chest or your neck, depending on how deep you're immersed. And that hydrostatic pressure creates the world's best compression garment. It's tight at the bottom and it's loose at the end, and so it pushes all your blood that tends to pool down in your venous system and all of the lymph and everything that's sitting in that third space interstitial area, all that pushes it back in to the circulatory system and pushes it up towards the core. And because it does that, especially if you're immersed at least to the chest level, it creates this large shift in volume. And so it actually assists the heart in returning blood back to the heart. And so you get this more powerful stroke volume. So every time your heart beats, you get a larger volume of blood ejected out of the heart. And so that means that you don't have to have as high a heart rate to exercise in the pool, because the volume, if you look at cardiac output, you're looking at stroke volume times heart rate. So the stroke volume goes up, and so the heart rate does not need to go up as much. And so essentially you're creating this efficient system of return of blood, which makes it possible to exercise at lower heart rates. Now swimming, you're not going to have the same hydrostatic pressure effect. So you're not going to get the same drive of volume back to the core. And so especially if someone is a poorly efficient swimmer, they didn't know how to swim, or they weren't good as a swimmer before they had their cardiac condition, you shouldn't recommend for someone to start swimming as an exercise after a cardiac event unless they're cleared by their doctor, because it's a very different thing to walk in the water or stand upright in the water and exercise versus swimming. Okay, secondly, there's a big difference between immersion to the chest and immersion to the neck. And again, if you want the specifics on this, look at the paper. But when someone is immersed to the chest, they're getting a large volume shift, yes. But the amount of shift in volume that occurs versus being immersed to, say, the nipple line versus being immersed to C7 is dramatically different. And especially when you're dealing with someone who has congestive heart failure or someone who has a valvular insufficiency, it's going to matter. So as a rule of thumb, if you've got someone who you say, yes, they're cleared to get into the pool as a cardiac patient, as a congestive heart failure patient, as a rule of thumb, just tell yourself chest deep or shallower. Don't go up to neck deep, because it really does make a difference. And again, look at the details in the paper. All right, number 3, decompensated heart failure is most people consider an absolute contraindication for water therapy. You are getting this massive shift in volume up to the heart, and if someone is already in a decompensated state, it's just going to create all sorts of havoc. So this is something that I would put firmly in your contraindications list instead of a precaution. Okay, what about someone who has severe valvular insufficiency? So you're basically saying their valves are not doing the job. They leak, or they don't shut, or they're partially stenotic. Well, again, you're putting this larger volume on the heart, which is stretching out the walls of the heart, which of course is going to make those valves leak even more. So if they have a severe valvular insufficiency, you might decide that that's not an appropriate patient for the pool. And, I hate to give you kind of a gray area there, but I can't make that decision for you. And unfortunately, subjective impressions are no guarantee that your ventricle is handling that increase in volume. So the research shows that you'll have these people, you put them in the water, they have congestive heart failure, you put them in the water and you ask them how they feel, and they feel good. There's no pain, there's no anxiety, and yet their left ventricle is not handling the load. So you cannot go by subjective impressions with that cardiac patient, especially in congestive heart failure. Okay, so some of the research seems to say that if someone has had a recent heart attack, less than 6 weeks old, that you should not let them get in the water, whether they're immersed upright or swimming. And that once the 6-week mark has passed, then there's kind of a gray area, and then they can be released to get into the water. And there's lots of evidence out there that says that mild and moderate congestive heart failure do quite well in the water. It's just when you start getting into a stage 4 or decompensated heart failure that you're just going to create some situations that you don't want to have clinically. Okay, and then as I said, in that paper I referenced several studies that say that not only is it safe for that congestive heart failure patient with stage 1, stage 2, and even stage 3 to get in the water, it's beneficial. All right, lastly, what about your hypertensive patient? There's a link to an article that talks about the temperature range that's generally considered safe for them, and anywhere between 88 degrees and 100 degrees seems to be appropriate. And hot tubs tend to run from 100 to 104 degrees, so you would not want to put a hypertensive patient in a hot tub unless for some reason their physician has cleared them to do so. Okay, how about pulmonary diseases? Well, again, there's kind of a myth that says, oh my gosh, you've got this, let's say, asthmatic patient, or you have someone with emphysema. You put them in the pool, and it's just going to create all sorts of problems. Well, sometimes it does. Immersion water does drastically affect the diaphragm. It changes the rib cage, and it changes what's going on with the diffusion in the lungs. And while that can be a bad thing, it can also be converted into a good thing. It can be essentially an exercise program. So there are some studies out there that say they have shown that there are mildly negative effects of immersion on lung function, but that even though you can look at these, let's say, forced expiratory volume, things that happen when you have someone immersed and head out water immersion, that it's still safe for the COPD patient, for the respiratory compromised patient. So the rule of thumb that we had for the cardiac patient was, okay, keep them chest deep or shallower. The rule of thumb with your respiratory patient is if you want immersion to become this exercise program, because the work of breathing becomes about 60% harder when you immerse someone up to their neck in the pool, just by being immersed, not by doing any sort of exercise program. But if you want the work of inhalation to become harder and that to be part of an exercise program for them, you want them to be immersed deeper. So for the respiratory patient, you want them to be somewhere between their chest deep and neck deep. You actually want to try and take them deeper if they can tolerate it. Okay, number 2, the effects of the environment itself, the chemicals in the air, the humidity, the temperature of that air as they breathe it in is really unknown. So if you've got someone and they walk into the pool area and they start to wheeze and their eyes are stinging, your pool is probably not properly ventilated, and that's not going to be a good environment for them. So certainly if it's bothering you as the therapist, please do not take your emphysema patient and walk them into a pool area that has all of these nasty chlorination byproducts that are not getting whisked away and handled by your air handling system. And if they start to cough or wheeze, especially on the deck before they ever get into the pool, you know that this is not an environment that's good for them, no matter what immersion and exercise would do for them. Okay, when you're working with that pulmonary patient, please have them bring their inhalers poolside. I had a patient one time who had a emergency asthmatic attack, and their inhaler was in their locker room. And there's nothing like, having to ask someone the combination of their locker while they're having an asthmatic attack to make you realize you really need to bring all the accoutrements poolside. Okay, while there is some evidence that exercise in the water is equally effective for COPD as land-based exercise, there's not a lot of conclusive evidence that it's more effective. So just something to keep in mind. And then lastly is that more and more the population of COPD and asthmatic patients are being recommended to use the pool if they have any sort of comorbidity makes it difficult for them to exercise on land, like obesity and so on. And then the last thing I want you to keep in mind is that poorly ventilated pools are not just hazardous to the patient, they're actually more hazardous to the therapist and the lifeguard staff and the people that are in the pool more often, which is why you need to have a properly ventilated pool. Okay, so let's move on in our list of precautions and contraindications. Any sort of immunocompromised patient, we talked about the patient with a low T-cell count and so on, you really do not want them sharing this communal bath, and so it would be appropriate for them to stay home, away from your public pool. Okay, take a picture of this, or look at this picture and tell me what you think is wrong. Anyone with an instability of ligament, capsule, or bone, the pool can be a great place for. Someone has a partial rotator cuff tear or they have a partial ACL tear, the pool might be perfect for them, but you do have to be aware of the fact that it is an inherently unstable environment and people have lots of freedom of motion, and so you have to rein that in and you have to control the environment to make sure that you're not going to take a partial tear and convert it to a full tear. The MS patient, the multiple sclerosis patient, oftentimes is thought of when you talk about thermoregulation. But there are lots of populations out there, pregnant women, children, that are notoriously poor thermoregulators. And if you put them in a pool that is anywhere outside of the thermoneutral kind of zone, which is somewhere between 92 and 94 degrees Fahrenheit, they're going to gain heat or lose heat. If they're not exercising, they're going to lose heat by being immersed in cold water, and they're going to gain heat, and even more so if they're exercising if it's in warmer water. So you do need to watch that, especially in people who don't have those thermoregulatory skills. I would say that you shouldn't just make an arbitrary cutoff and say, oh, the MS patient can't come into this therapy pool because it's warm. You should probably let them try it and see how it does for them. All right, anyone that's prone to ear infections, there's a lot of literature out that says that surface swimming, and certainly I would put therapy on that, is no great shakes, that there's no increase in risk to ear infections just by being in the water and having occasional water splashing in your ears. Now, if you're planning on having a tea party at the bottom of the pool, then you probably need to talk to the physician about that before you do so. Okay, seizure disorder. I'm going to flip the slide just so that you don't actually have one watching it. We'll come to diabetes here in a minute, but I got a call the other day from someone who says, I have a patient, it's an adult, they're seizure prone, they haven't had a seizure in a year, they have their driver's license, and my therapist doesn't want to treat them in the water because they're afraid they're going to have a seizure. Well, the pool's actually a lovely place to have a seizure if someone holds your head up above the water. It's just more the issue of the after effect of the seizure. So you have to be concerned about the fact that who's getting the patient out of the water, who's going to monitor their vitals, who's going to get them dry, who's going to get them dressed, and then how are they going to get home. And so when I was the manager of a therapy pool for children, the kids that were there had seizures all the time. It wasn't really an issue because the parent would take care of them. But for the adult, we had a 2 strikes and you're out policy. If you had 2 seizures in the pool, then you couldn't come back in until you were cleared by a physician and had been, I think it was 6 months, between seizures. It's just because it was a risk to put someone, off in the corner and move on to treating another patient. Okay, diabetes, all I'm going to say about this is that it's very possible to put someone in the water and 45 minutes to an hour later after exercising have their blood glucose drop 30 points. And so if someone comes in at 90 or an 80 and you exercise with them in the pool, just be aware that you might put them in a hypoglycemic state and that they should have something poolside to make sure that that doesn't happen. If someone has angina or angina, depending on the region of the country that you herald from, if it is brought on by a certain level of exertion, then obviously you just stay shy of that level of exertion. But if it's unpredictable when it comes on, then you may actually be having a patient throwing arrhythmias in the water, and that's bringing on that angina, and you don't even know it. And so if it's not a predictable chest pain, and you're sure it's not anxiety, then this might be something that makes you think, let's not chance it and put the person in the water. Okay, autonomic dysreflexia, just think, out of control blood pressure, oftentimes in a spinal cord injury patient. The most common predisposing factor is a nice big tug on the catheter, an indwelling catheter, to help them spiral into this out of control dysreflexia. And, so if you have someone with a catheter and you put them in the pool, then you're going to want to make sure that the catheter is not waving in the breeze, and a lot of times a pair of biker shorts will keep it contained. If someone has hemophilia or they have rheumatoid arthritis and they're in an acute flare-up stage, then they're not supposed to be exercising, and exercising in the water would be included in that. And it's just in those brief bouts of time that sometimes hospitalize those patients. I'm not talking their general life that they seem to be in a flare-up, but I'm talking about those times that they're actively breaking down their joints. It's not appropriate for them to be exercising. Okay, if someone's already dehydrated, you're going to put them in the pool, and they're going to become more dehydrated. That's just the facts of being immersed. If someone already has a fever and you put them in the water is the same temperature as their skin, and then you have them exercise, you might be elevating their fever. Okay, what about chemotherapy or radiation? If someone is on chemotherapy, just a thought, as they're being given this medication that has heavy metals in it, and their body tries to get rid of these contaminants, and so perhaps they're excreting some of them out on their skin. There's no studies, there's no evidence to show that it's possible for chemo medications to leach out into the water, but it's just a thought, something that you want to think about. What about the radiation patient? Well, radiation patient's skin becomes very hyperreactive, and a lot of times people will develop contact dermatitis before they never had any sort of situation like that. And so you'll put someone in a pool after they've had a radiation, and all of a sudden they're going to develop a sensitivity to the chlorine that they've never had before. If someone's on dialysis or they're already taken diuretic, you just need to factor that in and make sure everybody that's associated with the process knows that they're coming to the therapy pool, because vertical immersion in the water creates diuresis. And so you're going to have your patient being naturally diuresed by being immersed in the water, especially if they're in there for something like an hour 3 times a week. And so you just need to make sure that you're not over-diuresing them, or that the people who are doing their dialysis are confused because they come after the pool and they're already diuresed, and they're having trouble understanding what's going on. Okay, what about wearing a transdermal patch, especially something like a fentanyl or a pain patch, and putting someone in the warm water and having them exercise? One of the conversations that we've been having recently on a e-list that I belong to is Dr. Bruce Becker, who's one of the kind of lead authorities in aquatic therapy. He's a physiatrist. Says, you take someone that has this transdermal patch and you put them in the water, and you have them exercise, and of course they're generating higher temperature from being in the warm water to begin with and not being able to throw off that heat. And that transdermal patch is actually going to let off more medication at a faster rate. So again, there's going to be a link to the discussion that we had on that e-list on this as an issue. Okay, and then we're just going to hit some kind of basics, things like spinal stenosis. It's the same precaution that you have on land, against excessive extension. It's just possible to do it without knowing it in the water because of the freedom of motion that you have. Osteoporosis, you put someone in the pool, they have osteoporosis in the pool. On land, they certainly have osteoporosis in the water. It's just possible for you to do joint mobilizations and movements in the water that would seem more excessive on land, and so you just have to be aware that it's still possible for someone to sit down and fracture their vertebra, or for you to do a joint mobilization and break a rib. Just because the water is this buoyant environment doesn't mean that their osteoporosis goes away. Someone has radicular symptoms, I would not put them in the deep end unless you have assessed their ability to do a recovery. So I tend to have someone try and go from a standing position to a supine position, and then back to a vertical position, and then to a prone position, and back to a vertical position, and then try and make sure that they can do that before I put them in the deep end and their legs dangling, because radicular symptoms can get exacerbated by a lack of control when your distal end is not fixated in the pool. Someone has excessive pain reactions, like what we used to call reflex sympathetic dystrophy. The pool can be a fabulous place to work on that, but you just need to be aware that lots and lots of turbulence and movements and noises and people in the pool can exacerbate this. Anyone who's just had a surgery, staples or other fixators, again, you need to clear it by the physician. It's probably a precaution and not a contraindication, but you need to go by what the individual surgeon has to say about it. A newly amputated limb, or one that has lots of maceration, you don't want their skin to be further macerated, and especially if they're working on building up tolerance to wearing their prosthesis. Anyone who's had deep vein thrombosis and has not gone through, heparin or Coumadin and hasn't been cleared by the doctor should be on, double contraindications to the pool if they're on, bed rest or restrictions for weight bearing and movement, because you've got the effective immersion plus the effective movement. If they're on any sort of restrictions to motion after surgery, or like a total hip or any sort of spinal surgery, or if they're on any sort of restrictions to weight bearing, just because they're in the pool doesn't mean they're not going to get weight bearing. So you do need to have the caveat of how deep that you're immersing them and what sort of weight bearing forces you're allowing. And then the last couple of things that we're going to talk about is if someone's combative or mentally impaired to the point of unsafe behaviors. The pool is kind of a rough place to try and get someone out of if they don't want to get out of the pool, and you may create a situation that's unsafe for everybody. The chlorine sensitivity we've already talked about. If someone who's prone to that is getting in the same pool, they're going to run into the same problems. If you have someone who has a cultural restriction on their modesty, there are actually now these things called tankinis that are for, they're actually called burkinis, that are for people whose faith prevents them from showing skin. But if someone is on a true restriction that doesn't allow them to be in an environment with someone not of their faith or allow them to be in your pool with men around, then that's certainly going to be a contraindication for some and a precaution for others. And then the last thing I would say is if someone is frankly hydrophobic, skilled therapy that's being billed to an insurance company is not the time to work on their fear of the water. It doesn't matter how wonderful you think the pool would be. It's just not appropriate to bill out for skilled therapy for someone who's afraid, truly afraid. Okay, the last thing that I'm going to say is I'm going to upload a little paper on the occupational hazards that the therapists themselves have to worry about. So you've got a recreational waterborne illness propensity. The more that you're in the water, the more you have to worry about the fact that you might get sick from something you're in the water. The contact dermatitis and rashes, the more that you're exposed to halogen, especially if your pool runs a high halogen rate, a 5 parts per million versus a 3 parts per million, the more likely you are to develop a contact dermatitis. Occupational asthma is just the fact that pools, the more poorly ventilated they are, the more likely you are to get something called lifeguard lung, especially if you spend more than 20 to 25 hours a week in the pool. And dehydration is one of these things that almost all therapists tend towards and almost no therapists notice. So take a moment to read the paper that is going to be in the uploads. And then the last thing I would just say is burnout. Therapists that work in the pool, I think, deserve accommodation because it's an extra step. You've got to put on your bathing suit, you've got to shower a couple times, you've got to stay in the pool area and breathe the, sometimes poorly ventilated air, and so you don't want your therapist to burn out and clump out on you. You really want to hang on to the people, and so you want to make some accommodations for them, the people that end up in the pool, perhaps more time for documentation and so on. All right, so the last thing that is left for you is just to look up the expert opinion and scientific literature which supports these, precautions and contraindications. You're going to find this online, and you can download it at swimatu.com/PREC, like precaution, 13. And you'll see that download in the bottom left-hand corner of your screen. You'll find some of the evidence that has been cited, some detailed descriptions of each of the precautions and contraindications. There's going to be a link for you to order our Aquatic Therapy Boot Camp Manual, which is kind of, the quintessential, it's like a 4-hour guide to starting up in aquatic therapy. And you'll be able to find all of that online. And if you enjoyed this format and you want to either attend a live instructional or a on-demand webinar in the future, then you can just go onto our website, swimatu.com/webinars. And the next one after this live instructional is on November 14th, 2013, and it's a Pediatric Strategies webinar. Okay, well, thank you so much for attending the Definitive Aquatic Precautions and Contraindications list. If you want to reach me, you can email me directly at asalzman@aquaticnet.com. You can dial our office, the Aquatic Therapy University, if you want to find out more about trainings, etc., at 800-680-8624. You can get all your downloaded information at swimatu.com/PREC, like precaution, 13, like 2013. And then after you've watched this webinar and you're ready to take your post-test and print out your certificate of attendance, you need to drop us an email, and then we will send you an invitation to take the post-test online. So you send an email to lsalzman@aquaticnet.com, and then you will get an email from ClassMarker, and that will tell you how to log in and take your post-test. And after you pass your post-test, you do have to pass 80%, but after you pass that post-test, then you can automatically print out a certificate of attendance or completion after the course. Okay, thanks so much for coming, guys. And again, just drop me a line if you have any questions. I enjoyed it.